this computer.
Mom's on too.
Cool. All right. Let's see if I worked out on my technical. So the only technical issues that I foresee is, one, this computer crashed for the first time this morning. Hopefully that won't happen. I restarted it. If it does, just please go back to the Zoom, log back in, and I'll get back on as soon as I can. And number two, if you hear an alarm go off, I might have to run really quick, but usually that doesn't take long. I am at my office in the hospital. So without any further ado, I'll show you why I've been so busy for the past year. All right, can everybody see just the slide? Okay. If you have any pressing questions, feel free to shout them out, but I will save time at the end for questions, and I might answer your question like later on in the presentation. So there will be time for that at the end. So this is my dissertation defense. It is anosognosia across the spectrum of Alzheimer's pathology and validation of a new measure. In front of you is a picture of otherwise healthy neurons. Those blue things are what lets us walk, talk, and breathe. But in yellow are beta amyloid plaques. This is one of the key responsible factors for Alzheimer's disease development. These plaques just kind of develop naturally, and usually we can break them down, but in an Alzheimer's brain, there's trouble breaking them down, and so it leads to neuron death and difficulty communicating with each other. Just thought that was a neat picture. So since you asked, anosognosia is a confusing word that comes from the Greeks. A means without, nosos, disease, and gnosis is knowledge, hence the strange name. It's used to apply to a lot of different clinical phenomena, but in Alzheimer's disease, it means the lack of awareness into cognitive or functional deficiencies. It was originally coined by this guy named Babinski in 1914 because he had these patients that were paralyzed on the left side of their body, usually the left side, and they would deny that the paralysis was happening. So they'd think that they were moving their arm when they weren't. And this was due to some right frontal issues, but he came up with this term. Self-awareness is commonly used also in the literature, just the capacity to perceive the self in relatively objective terms while maintaining a sense of subjectivity. And then insight. So these are all kind of similar words under the same kind of construct, but anosognosia, essentially think lack of insight. I'll kind of refer to both insight or anosognosia depending on where it makes the most sense, because it creates kind of like a double negative. It can be confusing at times, but so why does anosognosia matter? In people with Alzheimer's disease, it presents in 20 to 80% of them. It's pretty variable. It tends to pop up later as the disease progresses. It can impede doctors' ability to diagnose early. So if a patient comes in and they say they're not having any memory difficulties, but they are, and they're not aware of it, then that doesn't help the doctor in diagnosis. There's also a greater risk of injury. If someone thinks they've already taken their medications 3 times in one day and they keep taking them, that's clearly going to be consequential. Poor treatment compliance, if we don't think we have a problem, we're probably not going to do anything about that problem. So that can be an issue. There's, of course, a greater burden on caregivers. There's frequently a lot of marital distress, arguments, like you already said that. It can lead to difficulty there. And then also this just helps us identify people who might need greater assistance. So the diagnosis, the key terms are kind of confusing. I'm going to be referring to MCI and AD. So when we think about Alzheimer's, it exists on the spectrum. And MCI, think of the middle of the spectrum, and AD, or Alzheimer's dementia, refers to the later end. We use the International Classification of Diseases. We use the DSM-5 more recently. The DSM-5 refers to this as mild neurocognitive disorder for MCI and major neurocognitive disorder for AD. But for consistency's sake, when I say MCI, I'm referring to the mild neurocognitive disorder, which is the initial stages of Alzheimer's disease, and then AD is more advanced. MCI can refer to other disorders like MCI due to vascular etiology, but MCI amnestic specifically means that the person is having a decline in the domain of memory, not other neurocognitive domains like attention necessarily or executive functioning, but memory typically pops up first in Alzheimer's. So you can think of memory decline, again, kind of on a spectrum. So as we age, it is normal to lose some of our memory and cognitive capacity. We have these very small changes in the brain, typically vascular changes. You think of them kind of like mini strokes, but they don't have like large consequences. But over time, these build up. And so we start to have more trouble than we used to. Now, the point at which that decline starts to become abnormal, and by abnormal, we mean compared to our previous abilities and also compared to people our age and education. When we start to see declines that are beyond what would be expected, then we start to become worried about Alzheimer's disease, specifically when it comes to memory. I won't get too big into the diagnostic criteria for that, but the main difference between MCI and Alzheimer's dementia is impairment in functioning. So in the MCI stage, you start to have the declines. You might start repeating yourself more, forgetting things, but it's not really impeding your day-to-day functioning. When we start to call it dementia is when you're starting to have those medication problems, you're paying bills twice or not at all, things like that. That's kind of the demarcation. But the main point is that this is a spectrum of decline. I'm not going to go big into the neuroanatomy on it, just give you a quick kind of overview. Alzheimer's typically starts in the medial temporal lobe and the hippocampus. It's not depicted here, but it's right in this area. And then as it progresses, it spreads kind of to other areas throughout the brain. The main model currently for anosognosia, specifically in Alzheimer's disease, is called the cognitive awareness model. The main point of this is that there's multiple areas in the brain that can start to fail that cause anosognosia. It's not one specific area. For instance, there's these areas we call like comparator mechanisms. So like if someone previously had a pretty good memory, but then they start to have these instances where they're forgetting things, they're forgetting names, the brain should take that moment and see, oh, we just made a mistake. And so you update what you currently thought about your memory ability with this new issue, and you keep updating it. So if you did not have anosognosia, then you would update your memory with, oh, my memory is getting worse and worse. In the person with anosognosia, that comparison is not happening. They're not updating their concept of who they are as this person with good memory. And so that leads to this analogy they call the petrified self, which is like that former conceptualization of who you were is no longer getting updated. You're kind of stuck there. So I'm just continually this person with great memory, even though like it's getting worse and worse because you're not updating it. And so that is responsible from degradation of areas like the anterior cingulate cortex here. The frontal lobe, especially the right frontal lobe, is related to this issue of not being able to update your self-concept. It correlates with measures of executive functioning, which this will pop up again later in our second study. We tested this model. And so lesions in this area are associated with anosognosia as well as decreased blood flow. That's as quick as I could be about the neuroanatomy there. So there's several methods of measuring insight, a lot of different ways. So the first is self-assessment, just asking the patient how they feel their memory is. There's several different questionnaires for that, but those are more just measuring the patient's perception of their memory. It's not necessarily telling you anything about how accurate it is. You would need an additional kind of measure for that, which gets into the caregiver-patient discrepancy methods. So you ask the patient their perception, but then you also ask a knowledgeable informant, such as a spouse or daughter, son, someone who can attest to their performance. And then you compare those two scores and typically calculate a discrepancy score. And the idea is that the higher the discrepancy, the higher the anosognosia, or the worse the insight. Informants, as long as they've like been with the client for a while, tend to be an accurate accurate estimator of patients' abilities in regards to memory. There's also the prediction post-diction. This requires specific administration of a measure, typically of memory, and then either before, for the prediction, you ask the patient how they think they'll do on that measure, or for post-diction, you ask them how they think they did, and then you compare it on that. Those aren't used quite as much, typically, I think, because they rely on an additional kind of quantitative measure of memory. Then there's the memory awareness rating scale. This one has several parts to it that incorporate both the caregiver and patient assessment, as well as the prediction and post-diction. It's the most widely used. It's also the most extensive. I've only seen it used like in research to kind of calculate anosognosia. I haven't seen it in clinical practice. Interestingly, the one that I do see in clinical practice is the geriatric depression scale, item 14. This is just one item on a depression scale that says, do you feel you have more problems with memory than most? And if the person says yes, then they're typically judged as, okay, they think they have a problem, so they have some insight. If they say no, then okay, they don't have the insight. It's kind of a qualitative thing. You can't do much with one item quantitatively, of course. But so this kind of emphasizes the need for a measure that's both empirically sound, but also clinically feasible. Neuropsychological assessment batteries can take anywhere from 1 to 2 hours on the low end to the more traditional time is 6 to 8 hours. So, recommending that clinicians adopt a new measure is not feasible unless it's kind of quick. At least that's the idea. So you can kind of think of insight on a similar spectrum as memory, like I showed you. In Alzheimer's, the research seems to show that in the MCI, like in the early stages, there's some intact insight. There's mixed findings on this, but some studies show that those with MCI amnestic do have some accurate assessments of their abilities. But as it progresses, it gets progressively worse. And this probably speaks to that, it's starting there just in the hippocampus in the memory area. And then as it progresses, it's affecting those areas involved in updating our self-concept and the access to those memories. So it kind of further petrifies the self, if you will. So this gets to this studies. There's 2 studies because one wasn't enough. In our first one, we wanted to create a measure that would bridge the gap between an empirical base, but also a clinically appropriate or feasible measure. So we didn't want to create this long thing that clinicians would be like, nope, don't have time for that. So the hypothesis for study 1 was just to validate the measure. And the hypothesis is that a brief qualitative measure of cognitive insight, we call it the cognitive coding form, or CCF, will be as effective at identifying insight into memory concerns as an established measure. And specifically, we use the self-rating memory function scale of the memory awareness rating scale. So I mentioned the MARS earlier. It's very long. It includes multiple components. We just use the self-rating portion of it. And this is what we came up with, 13 items. These were collected based on some previous measures, as well as common themes that we identified in the reports and the interviews at the clinic that we were working at. And I'll just run through them quickly. But so repeating questions, poor judgment, problems with financial affairs, decreased interest in activities, wayfinding difficulties. Now you'll see a couple underlined here. This was added after study 2 because it assisted in clarifying the item. But so wayfinding difficulties means both walking and driving, like walking into a room and not knowing why you did, kind of thing. Word finding difficulty, increased reliance on calendars, difficulty completing self-care activities, trouble cooking, forgetting to take medications. This was a big one, item 11. So cognitive decline, so just some kind of reference to these problems are getting worse. And then specific reference to the decline being not normal aging, and then difficulty managing appointments. So essentially, code had 2 raters. We practiced on some reports that weren't included in the actual studies. They were excluded due to like different diagnoses or some of the other exclusion criteria. So I had 2 raters in both studies. They were blind to each other's ratings, and then I met with them at the end to break any disagreements that we had and to come up with a agreed upon coding. But so you essentially you sum them all up and you can create a total score. So to walk you through an example of how we used it, so this was for this, we have the self-report and the informant report. The self-report is obtained from the clinician's report that they wrote up after the evaluation. So here they wrote, he reported gradual cognitive decline over the past 2 years with a more noticeable decline in the past few months. So that's item 11, you would code for that one. He reported problems with general forgetfulness, losing his train of thought, word finding, there we have item 6, forgetting conversations, repeating questions, item 1, and slower thinking. So that person would receive a 3 on the self-report CCF. The informant report was obtained through this questionnaire that anytime a patient comes with a family member or friend, that family member or friend is given this form. They're asked to please describe your understanding of the client's current memory, attention, speech difficulties, emphasize any changes within the last 1 to 2 years, and include the approximate date the symptoms began, if they began suddenly or gradually, and if you've noticed any worsening over time. And so here's an example that we got on that. Lots of confusion. It started gradually and progressively has gotten worse. Item 11. He can't remember anything. At times, he does not know me. He can't use the TV remote or dial the telephone. He can't keep up with his bills. There's item 3. I go to his house at breakfast, lunch, supper, and bedtime to give his medications and blood sugar and shots if needed, where in the past he has taken care of it. And so there we have the medications. About 2 weeks ago, he did not know who he was. All of it started around December 2012. So as you can guess, this is probably pointing towards a more advanced level of the disease, but that person would also score a 3 on that one. So the measures for study 1, of course, the CCF, and then the memory functioning scale self-rating form from the MARS. So it contains just 10 items about how the patient would manage in a specific situation. So for example, you meet someone and are told their name. Later on, you meet them again and you need to remember their name. So then you state if you can manage never versus, I forget what the other ones are, but up to always able to manage on a Likert scale. We also included some other measures for discriminant validity, which I'll go into when we get to that section. So we ended up with 31 patients, pretty even spread on gender. Most were white and non-Hispanic. Average age was 69, pretty educated, 14 years. Most were married. The diagnostic group wasn't perfect, but we had 9 in no diagnosis, 15 in the MCI group, and 7 in the AD group. So we felt like this would be enough to at least start kind of looking at the CCF to look at the validity of it. So these patients received, so they were referred by their primary care physician to an outpatient neuropsychological assessment clinic. They do an interview when they first get there that takes like 30 to 60 minutes. And then they take a 1 to 2 hour neuropsychological assessment, various tests. We counterbalanced the MFS before and after the test to make sure that patients going through that test, it didn't change their performance or change their perception of how their memory is. And then I mentioned we did several trials of the CCF before actually using it. And the inter-rater reliability was pretty good. 0.7 is acceptable, but we had a 0.87 for the self-report, and then 0.96 for the informant. So there was some good agreeability, though of note there were 31 cases, so there was less to kind of rate. So there were no significant pre-post test differences, meaning that taking the full assessment did not influence how they rated their performance on the MFS, so we did not control for that. You can kind of see a distribution of the items. Can y'all see my pointer when I do this? Okay. So here we have the 13 items, and then kappa is the inter-rater reliability, and then the number coded. So you can see kind of the more popular items were word finding difficulty, worsening cognition, and then some of them weren't endorsed at all. Some of them are starred here, and I'll get into this more in study 2, but there were some weak items either due to inter-rater reliability or because they just weren't endorsed frequently. These are the ones that were ultimately removed for our study 2 analyses, but we wanted to confirm that they were weak in study 2. So we'll get back to that, but overall pretty good inter-rater reliability. Yeah, you can see that 8 and 13 were problematic on the inter-rater reliability there. So a couple specific items, and those 2 were removed later. So again, the goal is to see if the CCF is valid. The first step is convergent validity, which is, does the CCF converge or correlate with other measures of the same construct? Are we measuring the construct that we think we are? Kind of. So first, we kind of looked at trends in the data. So down here, we've got healthy controls, MCI, and AD. So pathology worsening kind of as we go down. The informants are reporting less concerns for the healthy control group, kind of in the middle for the MCI group, and the most for the AD group. This is what we expect. Informants tend to be accurate estimators of their loved ones' abilities. Problems increase as pathology increases. We see the reverse when we look at the self-report. The healthy people actually state that they have more concerns than the MCI group, and then those with Alzheimer's dementia say that they have the least concerns. They're doing the best. And this is what we would expect, because as AD progresses, insight decreases, and so they would think that they're having more concerns. So this lends a bit of credibility to our measure. And then since there's discrepancy scores were common in the literature, we did that. And this tells us kind of some more. You see that there's actually a negative discrepancy for the healthy controls. So this means that they're underestimating their abilities basically compared to their informants. They think that they have more problems than their informants do. Interestingly, the MCI group has about the same perception. So there's almost no discrepancy. They seem to be pretty in line with the informants. But then when you get in the AD group, the discrepancy is largest. Now with the MFS, it did not trend as expected. So higher scores on this indicate better abilities in those specific scenarios. And so based on these trends, you would think that insight is intact as measured by the MFS, but that doesn't really correlate with what we know about the progression of anosognosia. So that's interesting. So we did correlate our CCF with the MFS as well. And we would expect that there'd be a significant negative correlation because more concerns on the CCF would correspond with worse MFS performance. That it trended as expected for the MCI and AD group, but not the HC. You see there was no significant relationship there. Not totally sure why this is. It might be due to the specificity difference. So the MFS is asking specific scenarios. It's presenting like in this specific scenario, how would you do? Whereas the CCF is just kind of general. Do you tend to, repeat questions or have word finding difficulties? Not sure. Also, this is underpowered. So just note that the interpretability of these findings are pretty low. However, the effects are still pretty large. So we would think that that would be robust with a higher sample size, but not totally clear The next step is discriminant validity. So we want to make sure that our measure does not correlate with other constructs that it should not correlate with. Specifically, there's no known relationship between anosognosia and working memory or processing speed or depressive symptoms. So that's what we used. These first two, the digit span, this is like you say some numbers and the patient says the numbers back to you, and then you say the numbers backwards and they have to give them back to you. That's a measure of working memory. And then the processing speed index is from two different tests that look at your ability to kind of both quickly and accurately complete visual tasks. And then depression symptoms. And this was measured using the geriatric depression scale. So fortunately, we had discriminant validity for the CCF on all three of these. It did not correlate with them. That is what would be expected. I did go ahead and run the same analyses for the MFS since we were seeing some strange trends, and also because I didn't see any discriminant validity in the work that was done on the MFS. And it did not correlate with working memory, but there was a strong correlation with processing speed and depressive symptoms. Again, I'm not sure why this is. It shouldn't necessarily, that relationship shouldn't exist. I will say that we did have trouble giving the MFS to patients with more severe psychopathology. Excuse me, I've been working here too long. With more severe Alzheimer's dementia. So those who seem to like do the worst in the testing had trouble knowing how to answer these questions. They didn't, the Likert scale confused them. Things like that, that suggests the measure might be too complex for people with advanced pathology. I won't go into too much detail on that, but that might be a weakness of the MFS. So now that we know the CCF at least sort of works, it does seem to measure insight. It shows some convergent and discriminant validity, suggesting it's valid. We wanted to put it to the test and see if it could predict clinically relevant information. This would also inform more on the construct validity of the measure. Does it do things that other measures of anosognosia do? So our first hypothesis, I'm getting tired of saying this word, was that anosognosia, as measured by greater informant patient discrepancy scores, will be significantly higher for those with dementia, followed by MCI and HC. We saw this in the graph on study 1. It trended as expected, but we wanted to go ahead and run it with more robust sample size. Secondly, hypothesize that anosognosia will negatively predict delayed memory recall performance. This was measured using the average of 2 different tests. I'll go more into that, how that was measured in a minute. But above and beyond depression and diagnostic group. And then last, to test the cognitive awareness model, does executive functioning significantly negatively predict anosognosia? I'll repeat those again later because I know you've already forgotten what I just said. So the procedure is the same clinic. We extracted the data from neuropsychological reports. The exclusion criteria were that they had specific comorbid disorders such as delirium, schizophrenia spectrum, or other psychotic disorder, post-traumatic stress disorder, or an intellectual disability. These are known to impede neurocognitive performance. Secondly, if the clinician stated that there was issues with effort, if they didn't seem to be putting forth full effort, they were not included. If they were already on any kind of cognitive enhancing medication, we had a specific list, but such as Aricept or memantine, Namenda, those weren't included. If the etiology of the disorder or the diagnosis was not specifically either no diagnosis or mild cognitive impairment, amnestic, or dementia, it had to be a specific reference that Alzheimer's disease is the possible or probable cause. Otherwise, it wasn't included. And number 5 is a similar point to number 4. So we collected until we had equal sample size in each group, 80 across each group, so 240 total. Pretty equal spread on males and females, pretty similar demographics. Most were white, non-Hispanic, Average age was 73, pretty educated at 14 years, and then most were married. These demographics here are pretty interesting. So you've got healthy controls, mild cognitive impairment, and then Alzheimer's, dementia, and then males and females. So you see that there were more females in the AD group than males. This is a finding in literature. The difference isn't huge, but it is shown that females are more at risk for Alzheimer's disease. Also, you see the age increases as the pathology progresses. So across diagnostic group, age is a risk factor, of course, for Alzheimer's disease. And then the opposite on education. So the more educated people were in the healthy control group, followed by MCI and AD. So the more you go to school, the less likely you are to have Alzheimer's. Maybe that's why I'm here. So one issue that we did want to address is kind of this tautology that exists. So the fact that some of the dependent variables that we're using and correlating with the diagnostic group was made based on those scores on those measures. So they kind of already inform one another. So we wanted to tether the diagnostic group to something other than just what the clinician made based on those measures. So all patients were given the mini mental status exam. Traditionally, this is not used diagnostically. So at this clinic, it typically doesn't contribute to their what diagnosis they give. But it's given a lot by medical providers, so it's a good kind of comparative tool. And so we found that there was a study that found the cutoff scores that essentially best lumps people into being either no issue, MCI amnestic, or Alzheimer's disease. And that's these cutoffs here. So in order to get into one of our diagnostic groups, they had to both have the diagnosis by the clinician and also their MMSE score had to fall into that range. It doesn't, fully remove that tautology, but we feel that it at least, we try to account for it. So then we get to our measures. They're given a lot of measures. I'm not going to go through all of them. I'll go through the relevant ones. The MMSE, I just mentioned, it's you can get 30 points, but it's kind of a global cognitive ability measure. The trail making test, this comes up in our third hypothesis, but there's two parts to it. Part A, they're asked to draw a line as quickly as they can, connecting 1 to 2 to 3 to 4, and they're timed on it. And then TMT-B, part B, is more challenging, and it's more of a measure of executive functioning. And for this one, you have to alternate connecting 1 to A to 2, 2 to B, B to 3, and so on. So you have to kind of quickly and effectively switch tasks, which is an executive frontal kind of job. Memory was assessed 3 different ways. So one was a word list, and they're given either the Ray auditory verbal learning test or the Hopkins. The Hopkins is shorter than the Ravel, and the discretion on the clinician to use either or is mainly based on the person's functioning. So if they get like a 50-year-old with, really seems like they could manage the Ravel, they'll give them that. If you get a 95-year-old, you don't want to put them through the suffering of the Ravel, so the HVLT is a bit shorter. But they both produce the Z-scores. And then the Wechsler memory scale, 4th edition, we use the story from that. So they're given a story, and then 20 to 30 minutes later, they're asked to recall the story. Same thing on the words, by the way. 20 to 30 minutes later, they recall the words. And so it's that delay that we're interested in, because in Alzheimer's, you're not saving that information, and so there's not much left on the delay. And then depression. So this comes up in the limitations section, but there's 4 different measures of depression, because there's multiple clinicians at the clinic, and also their use of which depressive symptom or which depression measure to use depended on the client's functioning. So the geriatric depression scale, there's 2 versions, the 15 item and the 30 item. It depended on, where they were at. Again, lower functioning, they're going to give the GDS 15. Then we also have the patient health questionnaire 9. It assesses depressive symptoms, but it uses a Likert scale, so it can be a little more difficult to use. So it's typically given to younger individuals. And then the Center for Epidemiological Studies depression scale. That's 20 items. It's a lot longer, and that one's given more infrequently. The geriatric depression scale is used the most, but what we did was we took standardized Z-scores for each measure based on all the patients that took that measure, and then we lumped those into one kind of depressive symptom category. So I won't go into too much detail on that, but they seem to also converge with the best available normative data for Z-scores on the depressive symptoms. So we felt that it still appropriately assessed depression. And then, of course, our measure, the CCF. All right, so you've seen this table before, but I added the study 2 here now. So again, these starred items, we felt after the second study, they needed to be removed. We only had, 3 endorsements on some of these. But the more popular items and the ones with good inter-rater reliability were retained. So repeating questions, trouble with financial affairs, word finding difficulty. And then, so these items, the ones that aren't starred, are the ones that were used in the remainder of our analyses that I'll be talking about. And then to throw in another measure of convergent validity, since we now had a bunch of people who had taken the geriatric depression scale, we compared that there. So those who said that they do versus don't have more problems with memory than most, we looked at the difference in discrepancy scores on the CCF. And what we found is that those who denied having more problems with memory than most had higher discrepancy scores than those who said they had more problems with most, suggesting that these measures are they're correlating with each other, and that again kind of points to some convergent validity for the CCF. So to test hypothesis 1, that anosognosia will be significantly higher for those with dementia, followed by those with MCI and the healthy controls. We just did a one-way ANOVA. All of the assumptions were met. There was one outlier, but it was expected. It was someone with Alzheimer's dementia who had like 6 concerns reported by the informant, but they said they didn't have any. That would be expected to happen with Alzheimer's disease. And also we ran it both ways, with and without the outlier, and it didn't make a difference. So just focus first here on the discrepancy scores. So we looked at difference in discrepancy scores between each group, and overall the model was significant, and each group significantly differed from one another. So you see a similar trend that we saw in study 1, where there's this underestimation for the healthy controls. There's actually also kind of an underestimation for the MCI, but it's closer to 0. And then those with AD have the largest discrepancy in the direction of overestimating their abilities or low insight. We also wanted to run this with just the self-report. Some patients show up and they don't have somebody with them. So can we still use the CCF if we don't have an informant? And the answer is yes. So overall, the model was significant. And again, the scores in each group were significantly different. So healthy controls report the most concerns, MCI in the middle, and then AD is the lowest. So you can still kind of use their report to judge, if they're reporting more cognitive concerns, then insight might be intact. If not, then vice versa. So the second hypothesis was that, there's a cat. Sorry, I get distracted easily. Anosognosia will negatively predict delayed memory recall performance as measured by the average Z-score of the memory measures above and beyond depression and diagnostic group. So to do this, I figured to do a moderation analysis, because this would also give us information about how the relationship between the CCF and memory changes across diagnostic group. So here you see this is kind of what we would expect. So we used a moderation analysis, Andrew Hayes's process macro for SPSS, which makes things a lot easier than how we traditionally do it. We only used 207 patients for this one because 12 weren't given one of the memory measures. Most of these were in the AD group. Typically, it's that they were so advanced in the process that they didn't need 2 measures of memory to say that they had disorder, so they just stuck with 1. There were 2 outliers on depression that were removed, and then 1 outlier on these statistics that calculate outliers in the moderation model. The assumptions were all met except the dependent variable. So delayed memory performance was somewhat non-normally distributed. It was a lot worse for the AD group, of course, but the skew and kurtosis wasn't significantly different, so we kept going, or it was in acceptable ranges. Overall, this model was significant. Depression was not a significant covariate, so that's good, but also the CCF was not significantly predictive of memory performance. That's what the main hypothesis was. We can still get some more information from this. There's a significant difference in delayed memory performance between all 3 groups, and that would be expected. Memory should be better for those with less pathology, worse for those in more advanced. But there were no significant interactions. The addition of the interaction was not a significant change to the model. And the simple slopes analyses were that the diagnostic group did not significantly moderate the relationship between the discrepancy scores and delayed memory performance. It's a lot of jargon, but here's what that looks like. Basically, these slopes, the relationship between the discrepancy scores and the delayed memory performance, those slopes they weren't significantly different between the diagnostic groups. It is kind of interesting, though, that the MCI and the AD relationship is pretty similar, but it's not for the healthy controls. I would guess that the positive relationship for the healthy control group is likely due to their underestimating. So like the more you underestimate you're doing, the better you're going to do, kind of thing. And then the similarity here may be due to a floor effect. So by the time you hit MCI amnestic, you're typically showing some pretty low scores on memory measures. So it could be that once you get into the AD, the memory doesn't necessarily change as much. It's still close to impaired, but these other areas are being affected. But then also this could be an issue with kind of the tautology, like we talked about. The memory scores themselves inform the diagnoses, and also anosognosia is a part of Alzheimer's disease. So as you know, you've got these diagnostic groups, they might kind of already be containing the anosognosia that we're trying to use to predict the performance. Okay, so the last one was to test the cognitive awareness model. Since everybody else did, if we throw our measure into there and it shows similar findings, then this again would speak to some construct validity. But the hypothesis was that executive functioning as measured by trail-making test B will significantly negatively predict anosognosia. We did a hierarchical regression. And the assumptions were met on this one. So together, depression and executive functioning accounted for 18.5% of the variance in insight. And this was significant. So both depression and executive function to a greater degree inversely predicted insight. So this does seem to suggest that the change in insight is at least partially due to change in executive functioning. So that supports the CAM. So I kind of did a little discussing as I went along, but key point here is that, so these batteries are often very long, and neuropsychologists do say that they're getting reimbursed for 60% of their time, which is nothing compared to like how much they're actually doing. And there's kind of a push towards reduced batteries. Most of them are still doing kind of the old model of long tests and sometimes 2 days of testing, but there's a push for shorter measures and shorter duration times, because you don't go into a doctor's office and get tests and it takes 4 hours of paper and pencil tests. So we feel the CCF does that, and that it is short, and it can kind of be done post hoc too. It doesn't have to be done during the assessment. But also it seems to be valid. We've got convergent validity with the MFS to the degree that we could. There seem to be some weaknesses in the measure. And then GDS item 14. There's a discriminant validity against working memory, processing speed, and depression that seems to exceed one of the most widely used measures that I could find. And then when you look at those trends, the construct validity seems to be there, as well as the fact that hypothesis 1 and 3 were supported. It's, changes with the progression of the pathology, and also it is predicted by executive functioning. So it seems that we are measuring anosognosia with the CCF. And so how it compares to other measures, I kind of mentioned the MFS, we only compared it against a part of that test, but that test is very long. It is empirically useful, again, for capturing like what exactly anosognosia is and how it progresses. But in terms of the clinical context or a clinical setting, it's not going to be used. And also the part that uses the post-diction prediction relies on a measure that is very uncommonly used, but you have to give that measure to use that part of it. Obviously, the GDS item 14 is only one item. You can't do much with that aside from qualitative observations. Also, so the CCF, it only has one item of memory, but it has several items of other areas of cognition that are impaired as Alzheimer's progresses. So most measures of anosognosia are only memory. So we feel by looking at other aspects of cognition that decline with Alzheimer's, we feel that that's good. And then, we noted hypothesis 2 wasn't supported, could be due to different reasons, but one other reason is, again, we only had one item looking at memory. This is the person repeating questions. When we did a post hoc analysis looking at does that one item predict delayed memory, it does. So just that one item significantly predicted memory. It was only for the informant report because not a single patient self-reported that they repeat questions, probably because they wouldn't remember doing so. But so that suggests that maybe inclusion of a couple more memory items might further increase the validity of this one. Limitations, of course, need to be noted. Any kind of archival study, it's difficult to establish causality. We didn't manipulate anything, but also, again, that tautology is the big one. So future studies should look at the CCF compared to measures that were not used, with it to create the diagnostic groups. So those kind of need to be separated to confirm that it's generalizable. Our use of a healthy control group, by definition, wasn't necessarily healthy control. So like they were still referred by their PCP to come have a neuropsych eval. That group of people might be different from someone you randomly sampled who had not previously had concerns. So it would be interesting to look at, is that underestimation issue just a product of like anxiety, health-related anxiety in the healthy control group? So they're healthy cognitively, but they have some anxiety about their performance. It might be more of a relationship seen with the MCI where there's not very many concerns for people who are generally kind of healthy. Also, how the information is obtained. We got it from the report that the clinician made, and then also from that form. Archivally, that is the best we could do, but creating a standardized way to get the information would eliminate some of the noise that might have come up in how we got that. So like a specific kind of form that can be checked off rather than just kind of like generally asking, or might be better for replicability. Depression, of course, I mentioned that was a limitation. We did the best we could in terms of creating the standardized Z scores, but there's still some going to be some variability there. And as I mentioned, I think the CCF could be strengthened by adding some more memory items. We have several functional items, but adding a couple more would further increase stability. So it could use a little tweaking. But implications, we had a pretty big sample size. Study 1 was low, but we validated it, and then we did study 2 with a large sample, which was robust enough to detect some effects. So we kind of see that the CCF can actually predict clinically relevant constructs. So executive functioning correlates with it, as well as the diagnostic group, which is useful information. The measure is short and sweet. We feel that it could be clinically feasible, and also it adds a degree of empiricism to something that was previously more qualitative. These questions are often part of a clinician's interview, but again, it's not quantified in any kind of way. It helps with our understanding of the neuroanatomical basis. Again, it's correlational with these measures of executive functioning, but it's doing what we expect based on an established model, and a lot of other research seems to show that these frontal executive areas are involved in it. So this lends an additional degree of credibility to the notion that, as it's progressing, it's affecting those other areas. And again, this is important because if we can quickly and efficiently identify people who aren't going to believe that they have an issue, that's going to help clinicians with their recommendations. The biggest struggle that I have with patients at this hospital are those who do not believe that they have an illness and don't believe that medications help them. And it's kind of a similar thing with Alzheimer's disease. If they don't think they have a problem, it's hard to help them. So if we can identify those people, then we can put some good interventions in place. All right. So I'm done, and I will open it up for questions.
I think just as a point, since we do have guests, this would probably be a good time for if the guests have any non-formal committee members, have any questions for Christian before we move to the closed sort of questioning session.
Right. Megan, Dan, usually, okay.
I have a question. So since your participants were largely highly educated and white, how do you think your results would be impacted with more diverse participants?
I think that's an excellent question. And so much research that's a limitation of so much research, is that we sample convenient samples, which is often white educated, the weird samples. Specifically, I think, I don't know if the relationships would change. I know that some, different demographics are more susceptible to Alzheimer's disease. So the scores might be lower in different groups, but I'm not sure how anosognosia kind of changes. I do know that stigmatization of mental illness in general is different across different cultures. And so that's one issue I've encountered here too. People don't kind of self-report issues. So that could certainly impede diagnosis, as they don't want to accept that they have, an issue. Regarding education, lower education is definitely a risk factor for Alzheimer's disease. So I would imagine that things would kind of pop bigger, like there would be more pathology, but I'm not sure exactly what it would look like. I think we definitely should replicate it with more diverse samples though. Mom, Dad, you got anything? Deja? You don't have to.
No, I was going to say, go ahead, Glenn.
No, you go ahead. We're good.
Okay, I'm gonna say I've been involved in this as long as anyone on this Zoom, and so I think I've answered all the questions I have interest in.
True. What were you gonna say, Dad?
No, I was just saying that we're good. Enjoy the presentation and don't have a question at this time.
Okay, cool. Well, thanks,
We're on
y'all.
our pace about our here, but y'all go ahead.
Yeah, it's good.
Cool. So for the final part, it's just going to be me and the committee while they decide my fate and ask me more harder questions. So thank you, Deja, Mom, Dad, and Megan for coming. You can sign off, please.
Absolutely.
All right,
Okay.
thank you.
Talk to you soon. Hang on a minute. You know me and laptops.
I'll just kick you out.
There we go.
I would ask if I wanted to report him. No, I don't want to report. Okay. All right.
All right.